All right, so we'll get started on the Journal Club for February 2022. Our first study was published in Clinical Gastroenterology and Hepatology. And it was a randomized trial comparing the impact of a 9-minute withdrawal time on the adenoma detection rate versus 6-minute withdrawal time. So in screening colonoscopies, the current quality indicators for colonoscopy recommend 6 minutes as the minimum standard for withdrawal time in negative colonoscopies by professional societies. However, the longer withdrawal time of 9 minutes in negative colonoscopies has been associated with the highest adenoma detection rates in prior studies. There are currently no randomized trials to date to have determined whether the 9-minute withdrawal time is superior to 6 minutes. And the aim of this study was to compare the adenoma detection rate between 6-minute and 9-minute withdrawal time during colonoscopy. So they conducted a randomized trial. It was a multi-center study conducted in China, conducted from January 2018 to July 2019. And patients aged between 40 and 85 years old undergoing colonoscopies for any of these following reasons for screening, surveillance, or diagnosis were included in the study. They excluded patients with history of colorectal cancer who had therapeutic colonoscopies previously or needed therapeutic colonoscopy as the indication, inflammatory bowel disease, any polyposis syndromes, and anyone with inadequate bowel prep. Patients were randomized in a 1-to-1 ratio to either 6 minutes or 9-minute withdrawal time. And as you can see, they set very specific minimum time limits for each part of the colon. And as you can see, for 6 minutes, they were allowed to spend at least 2 minutes in the cecum and ascending colon, 2 minutes along the transverse colon, 1 minute in the descending, and 1 minute in the sigmoid and rectum. For 9 minutes, the time spent in the ascending colon was longer at 3 minutes, as was the time spent at transverse colon and descending colon, with 1 minute reserved for the sigmoid colon. They had alarms at various parts of the screening of the colonoscopy procedure to remind the proceduralist to when they can move on to the next stage of the colon if they had finished an exam there. Okay, they also excluded from the withdrawal time, any times taken for biopsies, and also time taken to perform any polypectomies. So as you can see, 513 patients were enrolled in the 6-minute group, 514 patients in the 9-minute group. And if you look at the various indications, the majority were performed for diagnostic purposes, about 2/3 of the cases. Here are the adenoma detection rates between the 6-minute and 9-minute groups. 6-minute group had adenoma detection rate of 27% versus 36.6% in the 9-minute group. The relative risk was 1.35, as in patients in the for patients in the 9-minute group, they were more likely by 1.35 times to have found an adenoma compared to the patients in the 6-minute group. And this difference was significant with a p-value of 0.001. Now, if you look at the various locations, as you can see, the adenoma detection rate was significantly better in the 9-minute group compared to 6-minute group in the right colon, transverse colon, and also when they looked at, when they reclassified as a proximal colon, with significant difference in these adenoma detection rates. When looking at the adenoma detection rates according to size, again, the 9-minute group was superior to the 6-minute group for finding small polyps and diminutive polyps with p-values of less than 0.05 for those cases, but was not the case for large polyps. For morphology, as you can see, for patients in the 9-minute group, the finding flat or sessile polyp was significantly better in the 9-minute group compared to the 6-minute group at 27 versus 19% with p-value of 0.02. The 9-minute group also was superior to the 6-minute group when finding tubular adenomas at 33 versus 23.8%. Now, when they looked at the adenoma detection rates according to various subgroups, main indication, gender, BMI, age, experience of the endoscopist, etc., as you can see, the p-value, if you can see here, shows, here is 0.03. It shows that the adenoma detection rate was significantly better in the 9-minute group compared to the 6-minute group in patients, in endoscopists who had performed 1,000 to 3,000 colonoscopies, i.e. the less experienced colonoscopists. If you look at the adenoma detection rate in the 6-minute and 9-minute groups, they're very similar at 34.9 versus 34%, and with p-value of 0.9. And so as you can see, the withdrawal time of 6-minute versus 9-minute doesn't seem to make any significant difference in experience, but does make a difference in less experienced colonoscopists. These are the secondary outcome measures. As you can see, the adenoma detection rate, as mentioned before, is better in the 9-minute group versus 6-minute group, as was the polyp detection rate at 58 versus 47.8%, with significant difference between these two groups with p-values of 0.01. If you look at number of lesions detected per colonoscopy, the mean number of adenomas detected was significantly higher for the 9-minute group at 0.5 versus 0.4 with p-value of 0.08. As you can see, there is no difference in any discomfort experienced after colonoscopy or adverse event rates between the two groups. These are the limitations of this study. This study was not confined to patients undergoing just screening colonoscopies. They also included colonoscopies for surveillance purposes and also for diagnostic purposes. The possibility of operator variation in performing inspection techniques and identifying anatomical landmarks may have affected the robustness of the study findings. The reporting of sessile lesions were only found in 5 of the 12 participating centers. And only academic centers were included in the study, which may affect the generalizability of the study results. So in conclusion, the take-home points from the study is that prolonging the withdrawal time from 6 minutes to 9 minutes significantly increased the adenoma detection rate, especially in the proximal colon and for less experienced colonoscopists. And the study therefore provides solid evidence that 9 minutes may be an optimal withdrawal time to improve detection of adenomas and sessile-serrated lesions and should be considered as a quality indicator. So that was our first study. This is our second study. This is published by Holmberg et al. In Gastroenterology this month. And this is looking at the incidence and mortality in upper GI cancers after a negative endoscopy in patients with GERD. GERD is the most common indication for referral to gastroenterologists for an upper endoscopy, but however, frequently returns negative results. And it is unclear whether endoscopy in patients with GERD is associated with risk reduction in the development of upper GI cancers or death from upper GI cancers in these patients in the future. The aim of this study was to assess whether and to what extent a negative upper endoscopy for GERD decreases the incidence and mortality from upper GI cancers and to estimate how long any such risk reduction may last. So this was a population-based cohort study, a retrospective study conducted in four Nordic countries, Denmark, Finland, Norway, and Sweden, They looked at patients with GERD and negative upper GI endoscopies, basically between July 1st, 1979 and December 31st, 1981. And patients with GERD diagnosis were identified using relevant diagnosis codes in national patient registries for each country. And then patients undergoing endoscopy were also identified from national patient registries using relevant procedure codes. And a negative upper endoscopy was defined as the lack of diagnosis of an upper GI cancer within 6 months of the endoscopy. The primary outcome measure in the study was a new diagnosis of any upper GI cancer, i.e. those occurring in the esophagus, stomach, or duodenum. So these are the baseline characteristics. They were able to identify over 1 million patients with GERD between these 4 Nordic countries. And as you can see, about 2/3 of the patients were older than 50 years and about evenly split in men and female patients. Now, this is the risk of upper GI cancers after a negative upper endoscopy in this study. So, as you can see, when you're looking at all the over 1 million patients with GERD and negative endoscopy, negative endoscopy exams in these patients with GERD, as you can see, if they had a negative upper endoscopy in patients with GERD, if they had a negative upper endoscopy, as you can see, the hazard ratio was 0.45, which means that they were less likely than someone who's had a positive upper endoscopy of developing upper GI cancers after the upper endoscopy. And this hazard ratio of 0.45, i.e. reduced risk of a risk reduction of developing upper GI cancers in these GERD patients were true for male patients, female patients, young patients less than 50 years old, and older patients over 50 years old. This is the adjusted risk plotted for a risk of upper GI cancers by year of follow-up after a negative upper endoscopy. And as you can see, over the follow-up years here at the bottom and the x-axis, the hazard ratio remains less than 1, which means that there is a risk reduction of developing upper GI cancers all the way up to year 5. And then it's above 1, although the confidence intervals are spanning 1. So this also means that there is not an increased risk of developing upper GI cancers, but remain fairly neutral. And then the risk kind of plateaus in the later years from year 8 onwards. When we're looking at adjusted mortality due to upper GI cancers by year of follow-up after a negative upper endoscopy, these authors calculated that mortality from upper GI cancers in GERD patients with negative endoscopy was extremely small at 36 cases per 100,000 person years. So the main limitation from this study is that although it's a large cohort study of 4 countries, it is still a retrospective study with inherent biases. And the authors were not able to collect direct data on some potential confounders for upper GI cancers, such as smoking, body mass index, alcohol intake, and lifestyle measures. And so the take-home point is that a negative upper endoscopy is associated with a strong and long-lasting decrease in incidence of upper GI cancers and mortality from upper GI cancers in patients with GERD. And therefore, this indicates that in patients with GERD, a one-time upper endoscopy appears to be beneficial. This is our 3rd study. This is published in Gut, looks at long-term outcomes after endoscopic treatment for Barrett's neoplasia with radiofrequency ablation and endoscopic resection. This is results from the national Dutch database over a 10-year period. So this study is important in our clinical practice because endoscopic eradication treatment is an established, effective standard of care treatment approach for patients with Barrett's esophagus and early neoplasia, that's low-grade dysplasia, high-grade, and early cancers. So the treatment approach involves endoscopic resection of visible lesions, followed by eradication of any residual flat Barrett's esophagus to minimize the risk of metachronous dysplasia. Sorry. And radiofrequency ablation is the most commonly and most established method for ablation. Treatment efficacy has been shown to be excellent in several landmark studies ranging from 74 to 98%. However, long-term durability of this method is unknown. So the aim of this study was to evaluate the short-term and long-term outcomes for all patients treated for Barrett's esophagus with dysplasia and or early esophageal cancer. So this was a retrospective cohort study using database from Barrett's expert centers in the Netherlands. This was conducted over a 10-year period from January 1st, 2008 to December 31st, 2018. They looked at two cohorts. First cohort was the RFA treatment cohort, which was defined as all patients with Barrett's esophagus and confirmed low-grade, high-grade dysplasia or low-risk adenocarcinoma defined as mucosal or superficial submucosal 1 cancer, which was well to moderately differentiated with no lymphovascular invasion and RO resection, who underwent at least one RFA treatment. And then they also looked at the RFA durability cohort, as in all patients with successful endoscopic eradication of Barrett's esophagus and neoplasia at more than 1 year follow-up. The primary outcome measure in this study was to look at the treatment success after treatment phase, which defined as complete eradication of Barrett's esophagus at first endoscopy. So this is the treatment protocol followed by these Barrett's esophagus centers, which are centers throughout the Netherlands specializing in the management of Barrett's esophagus, with all the endoscopists having undergone special training as well as the pathologists. And this is the treatment protocol that they all followed during the study period. Patients who are referred for Barrett's esophagus with confirmed low-grade dysplasia, high-grade dysplasia, or early adenocarcinoma undergo endoscopy with sampling. And then what they do is they treat the patient at 3-month intervals. If they have a visible lesion, endoscopic resection is undertaken. If they have any flat areas of Barrett's esophagus, that's circumferential by more than 2 centimeters, circumferential RFA is performed. At least one focal RFA, including circumferential ablation of the cardia, is undertaken, and any residual Barrett's islands are touched up with endoscopic resection or APC. After complete eradication of Barrett's esophagus on endoscopy, the cardia was biopsied, and then they were allowed to perform a focal RFA of the cardia one time if they noted an intestinal metaplasia in the cardia on repeat biopsies. So as you can see, 1,386 patients were included in the treatment cohort. And for the durability cohort, 1,154 patients met inclusion criteria. As you can see, the worst overall histology was early cancer in about 43% of the patients included. 30% had high-grade dysplasia and about 27% had low-grade dysplasia. Endoscopic resection was performed in 62% of patients, with ESD performed in 2% of the cases. The total RFA sessions were median of 2 in both groups. Now, if you look at the rate of recurrence over a very long follow-up period of greater than 108 months, basically, which is nearing, almost 8 to 10 years, the recurrence rate was low at 3%, and this conferred to annual risk of about 1%. And as you can see, the percentage of patients in the study cohort following this protocol in the Netherlands had extremely low recurrence rate. And you can see this is almost a complete plateau starting from the baseline. These were the adverse events that they encountered during the study period. At least one complication was encountered in 21% of cases. Stenosis was encountered in 15%, post-procedural bleeding in 4%, and perforation in 0.8%. This was the diagnostic yield of random biopsies during follow-up. And as you can see, when they performed random biopsies of the cardia, intestinal metaplasia was found in 7.2%, and low-grade dysplasia and 0.73%. Interesting, if you look at this right column here, none of these patients had progression to high-grade dysplasia or early adenocarcinoma. So the limitation of the study is that they looked at retrospective collected data with obviously inherent risk for bias. The results are applicable to patients undergoing RFA because this was part of their standard protocol at in the Netherlands. Appearance of cardia during surveillance and procurement of biopsies of the cardia may have been operator dependent. All endoscopic treatment took place in expert centers in the Netherlands, which obviously will limit the generalizability of the study results. There was also no data on the treatment regimes used during radiofrequency ablation. So the main take-home point from this study is that after successful radiofrequency ablation treatment and endoscopic resection in patients with dysplastic or neoplastic Barrett's esophagus, long-term risk for dysplastic recurrence was very low at 1% per person year. With all recurrences detected as endoscopic abnormalities rather than through random biopsies. There was also no association between 3 monthly endoscopies in year 1, improving patient outcomes in the study, and therefore more lenient follow-up intervals are recommended after this study by the study investigators. And they put emphasis on careful endoscopic inspection rather than relying on random biopsies of the neosquamous epithelium and cardia to detect recurrence. This is a final study. This is, I felt it was GI relevant / GI adjacent because we do have a lot of referrals for patients with C. diff infection, and this is published in the New England Journal of Medicine during January, and it's looking at oral microbiome therapy for preventing C. diff infection recurrence. And this was a randomized trial in NEJM. So Clostridioides difficile infection or C. diff infection is associated with 460,000 cases of infection and 20,000 deaths per year in the United States. Clinical outcomes are suboptimal because although vancomycin and fidaxomicin, up to antimicrobial agents used to treat C. diff infection, lead to symptom relief by killing the bacteria that produce the toxins that cause colonic inflammation and diarrhea, they do not kill C. diff spores, which can obviously then germinate into toxin-producing bacteria after discontinuation of the antibiotic treatment. Most recurrents occur within days to weeks after completion of antibiotic therapy, when microbiome description that occurs after cessation of antibiotics facilitates C. diff spore germination. Therefore, sustained clinical response is required. It requires microbiome repair. And so C. diff treatment involves killing the bacteria and also being able to stop C. diff spore germination. So SER-109 is an investigational microbiome therapeutic agent composed of purified firmicute spores for the treatment of recurrent C. diff infection. And the aim was to look at the safety and efficacy of SER-109 in preventing C. diff infection. This was a phase 3 double-blind randomized placebo-controlled trial conducted in 56 centers in the United States and Canada. So it's conducted over almost an over 3-year period from July 2017 to September 2020. Patients with at least 3 episodes of C. diff infection received SER-109 versus placebo after standard of care antibiotic treatment. So inclusion were having at least 3 episodes of C. diff infection within 12-month period with resolution of symptoms while receiving 10 to 21 days of standard of care antibiotic therapy, which was vancomycin or fidaxomicin. The patients were randomized in a 1-to-1 ratio to either receive the SER-109 or placebo, with stratification performed according to patient's age. 65 years of age was the cutoff, and the type of antibiotic received for treatment, vancomycin or fidaxomicin. They received 4 capsules a day over a period of 3 days in both groups. Obviously, placebo received placebo, and SER-109 group received SER-109. Patients were monitored for 8 weeks for recurrence, a recurrence was defined as at least unformed bowel movements a day over a 2-day period with positive C. diff stool toxin assay. The primary outcome measure was to compare SER-109 with placebo and the risk of C. diff infection that recurred up to 8 weeks after treatment initiation. These are the baseline characteristics. 89 patients were enrolled in the SER-109 group, 93 patients in the placebo group. As you can see, the majority of patients that were enrolled were Caucasian, and antibiotic regimes that were used to treat the active C. diff infection in patients enrolled were vancomycin in the majority of cases, about 73%, and fidaxomicin in 27%. And this is the primary outcome, the recurrence of C. diff. So as you can see, the recurrence rate was 12% in the SER-109 group versus 40% in the placebo group, and this difference was statistically significant with p-value of less than 0.001. And so patients in the SER-109 group had a significantly lower risk of developing C. diff infection recurrence with a relative risk ratio of 0.32. And this difference, as you can see, p-value was less than 0.001. Could everyone make sure they've muted, please? Thank you. Now this is recurrence according to age and type of antibiotic therapy that we used. As you can see, the risk reduction in recurrence of C. diff in patients receiving SER-109 also occurred in patients less than 65 years of age, and also in those more than 65 years of age. And also, as you can see, SER-109 was successful in reducing the risk of C. diff recurrence, whether they were taking vancomycin or fidaxomicin. So the type of antibiotic received for treatment doesn't appear to impact the efficacy of SER-109 in preventing C. diff infection. Any adverse event were noted in 93% of SER-109 group and 91% of the placebo group. They attributed about 50% adverse event rate to that related to SER-109 or placebo, although serious adverse event rate was low, 8% in SER-109, 16% in placebo. And as you can see, there was a whole variety of adverse events that were encountered, but in both groups. So commonly there were GI disorders, fatigue, chills, nervous system disorders. There was some respiratory symptoms, renal disorders, etc. The limitation of this study is the low inclusion of minority populations. The majority of patients enrolled were Caucasians, and relative short follow-up period of 8 weeks. And take-home point is that in patients, the symptom resolution of C. diff infection after treatment with standard of care antibiotics, oral administration of SER-109 was superior to placebo and in reducing the risk of recurrent C. diff infection. So to recap, Prolonging withdrawal time from 6 minutes to 9 minutes significantly increased the adenoma detection rate, especially in the proximal colon and for less experienced colonoscopists. This study provides solid evidence that 9 minutes may be an optimal withdrawal time to improve detection of adenomas and cell-saturated lesions, and should be considered as a quality indicator. Negative upper endoscopy is associated with strong and long-lasting decreases in the incidence and mortality in upper GI cancers in patients with GERD. And so in patients with GERD, a one-time upper endoscopy appears to be beneficial. After successful RFA treatment in patients with Barrett's esophagus and neoplasia, long-term risk for dysplastic recurrence was very low at 1% per person year, with all recurrences detected as endoscopic abnormalities rather than through random biopsies. Also, these authors found that there was no association between 3-monthly endoscopies in year 1 and improved patient outcomes, and therefore more lenient follow intervals can likely be adopted, with emphasis on careful endoscopic inspection rather than relying on random biopsies of neosquamous epithelium and cardia. And now finally, in patients with symptom resolution of C. diff infection after treatment with standard of care antibiotics, vancomycin or fidaxomicin, oral administration of SER-109 microbiome was superior to placebo in reducing the risk of recurrent infection. This concludes our Journal Club for February. Thank you so much for joining us this morning, today. Our next Journal Club will be the first Wednesday of March, which is March 2nd, 2022. Thank you so much for joining us today, and I hope you have a wonderful day, week, and month. Thank you so much. And happy Lunar New Year for yesterday, in anyone who celebrates. Thank you.